Welcome to SARC Talk. SARC is a nonprofit cancer research organization that develops and manages clinical research trials in pediatric and adult sarcomas. SARC Talk is a podcast to discuss activities of SARC, interview sarcoma research leaders, and review scientific initiatives in the sarcoma field.
Welcome to SARC Talk, episode 13. My name is Scott Okuno, medical oncologist at Mayo Clinic and chief medical officer of SARC. All episodes are posted on our website, Spotify and YouTube, SARC channel, and wherever podcasts are available. Please subscribe and submit comments because we do look at them. It is my pleasure today to have Dr. David Kirsch, radiation oncologist at the University of Toronto, as our guest for SARC Talk. Dr. Kirsch did his undergraduate at Duke University, had a BS in biology. He did his MD PhD at Johns Hopkins. He is presently he did his radiation oncology training at the Mass General and some at MIT. And then he went back to Duke to do his residency, and he was on staff there. More recently, he is now transitioned. He is now director of radiation medicine program, head of the Department of Radiation Oncology, named professor of Peter and Shlia Godso, and professor of radiation oncology at the University of Toronto at Princess Margaret Cancer Center. It is our pleasure to welcome Dr. Kirsch.
Scott, great to be here with you.
You know, Dr. Kirsch has been involved with SARC for multiple years, and maybe it'd be important for our audience to please tell us how you got interested in radiation oncology and specifically how you got interested in sarcoma research.
Well, Scott, so my interest in radiation oncology started from a young age. So my father was also a radiation oncologist, so I kind of knew about the field growing up. And when I went to medical school, I was interested in oncology and spent some time doing surgery, medical oncology, pediatrics, and decided that radiation oncology was going to be the best fit for me. Kind of like the combination of being able to treat patients that were young and old, men and women, palliative cases, but also curative cases. And then with radiation therapy, we have to design patient-specific treatments. And I found that problem solving really interesting.
Interesting. I didn't know that your father came through the radiation oncology field. As you know, it was a different time in that era. You've also been involved with SARC for many years as well. Maybe you can share with the group too, is what your role has been and evolved in SARC.
Sure. So I've been involved with SARC in a number of different capacities. With the SARC Spore, I had a pilot project or two studying basic science of how sarcomas develop and how they metastasize. There was also there was a sarcoma research group that I helped participate in and then led for a number of years to help promote translational research towards clinical trials. And then more recently, over the last few years, I've been a PI of SARC 32. So I've had multiple roles within SARC, and it's been a great organization to be involved in.
You know, our paths have continued to cross during our time at SARC, and I do remember when you were in the development of the therapeutics group, you built that out, and then you chaired that for some period of time, and then the transitions continue to occur, and now you're leading a major study in which we'll get to. You know, part of it, you did say that you enjoy the spectrum of kids, adults, old adults, curative intent, and palliative intent, and that's what radiation does. However, you also have a lab as well. So how did you decide to start doing lab? Because many of us might not understand what lab in radiation oncology is and how you've used that lab to start the translation to clinical trials.
Well, when I was an undergraduate student at Duke, I learned about the work of Brown and Goldstein, who were physician scientists who they discovered that the LDL receptor was mutated in young adults with familial hypercholesterolemia. They're patients that were getting heart attacks. And I realized that one could do basic research that could make discoveries that could impact patients that you would never see or treat. So I got interested in basic research and did a PhD, and have had a lab now of my own now for almost 20 years. And I think that the work we do in the laboratory, we study how sarcomas develop, how these tumors grow and metastasize, but we can also use our genetically engineered mouse models of sarcoma as a platform to test novel therapies. One of the therapies that we've been testing in the lab is radiation therapy with immunotherapy, and that's the what we're studying in SARC-32 with radiation therapy and pembrolizumab.
That's a perfect point. And, this study was initiated or at least conceptualized multiple years ago. And can you share how using some of the present SARC studies that we did in the past, part of your lab, of how you and your team decided to study this and put together the proposal and ongoing conduct of SARC-32?
Yeah. So really the proposal for SARC-32 came about from two streams. One was preclinical research from my own lab, but many others around the world, indicating that the combination of radiation therapy with immune checkpoint inhibition could have synergy and promote systemic immune responses against tumors. And then there was the work of the SARC-28 investigators who tested the anti-PD-1 agent pembrolizumab. And they showed that in certain subtypes of sarcomas, specifically undifferentiated pleomorphic sarcomas, and to a lesser extent, pleomorphic or dedifferentiated liposarcomas, that patients with metastatic sarcomas could respond to anti-PD-1 pembrolizumab. But importantly, there were other subtypes tested that did not respond well. And so based on the work of the SARC-28 investigators, we proposed to test the combination of radiation therapy with anti-PD-1 pembrolizumab, specifically in undifferentiated pleomorphic sarcoma of the extremities and trunk, as well as with a dedifferentiated or pleomorphic liposarcoma of the same sites.
Correct. And this study, maybe you can describe to the group here, is that this is not just here in the United States, this is an international study. And more importantly, can you maybe give us an idea of where we are with our accrual to date as of the time we're recording?
Yep. So we're recording today on November 10th. We have 144 total patients to be randomized, and we've enrolled 143. So and the final patient, I think I just heard today, is signed consent. So hopefully that'll be, as long as they're eligible, that'll be our final patient for the study. And patients are randomized between our standard arm, which is preoperative radiation therapy, 50 gray and 25 fractions, versus the same radiation therapy before surgery with pembrolizumab given at 200 milligrams IV per patient dose before, during, and after radiation therapy. So it's every 3 weeks. And then after surgery, those same patients get adjuvant pembrolizumab up to 14 cycles.
So as you kind of said, this is almost a completed study, but you've done a lot of work and pulled together a lot of different groups to help support this, and other collaborators that we have been very blessed to have part of this group as well. Maybe you can share some of your outside the U.S. colleagues as well.
Yeah, so we've enrolled patients at a number of U.S. sites, but especially for a study like this where it's histology specific, it's really been essential to have a multi-institutional clinical trial, but also a multinational clinical trial. So we have colleagues in Montreal in Canada, in Milan in Italy, and 3 centers in Australia. And our Australian colleagues have especially done a great job with accrual, especially during COVID, which was a very difficult time for accrual. And it's been wonderful to work with our international colleagues on this important study.
We do appreciate your leadership in this study. It's been designed very rationally in picking what groups of patients based on studies that were done at SARC, based on the work that you've done in the lab to design and conduct a study internationally. And hopefully we'll get some information and hopefully improve the care of our patients with these 2 types of extremity undifferentiated pleomorphic sarcoma, as well as dedifferentiated liposarcoma. So for those listening, stay tuned, because we hope to finish out this study for completion and then follow and see whether or not there's an impact.
No, I think, Scott, we're most excited, of course, to see the outcomes of the patients in the total group, but also we've embedded within our study a very rich correlative science evaluations. So we have pre-treatment biopsy specimens in all the patients. We have surgical resections of the tumors specimens as well. And we also have blood that we're collecting before, during, and after preoperative radiation therapy with or without immunotherapy, and then also after surgery. And the SARC-28 investigators, along with colleagues in France, identified a gene expression pattern, which they call the sarcoma immune class, that was enriched in immune cells. And so we have a pre-specified subset analysis that we will be doing to look at the outcome for the patients in the sarcoma immune class E category. And so I think even if the overall study doesn't show benefit for all patients lumped together, we may identify subgroups of patients that are, particularly will benefit from this drug. And then even if we don't see a benefit to the drug, I think that the rich correlative studies will help teach us so much about human sarcomas that we can do from our genomic analyses, our circulating tumor DNA analyses that are ongoing, and the analyses of the immune response through our mass cytometry of peripheral blood mononuclear cells.
That brings up the point that I forgot too, and we try to be positive. We also want to know if it does work, why does it work? Which population does it work? I know we got to think the other way too, is if it doesn't work, why it didn't work as well. But I think, I think the effort and forethought of having these predefined correlative studies is isn't a hugely important part of this study as well. And yes, the radiation, yes, the drug therapy is important, and outcome of disease-free is important, but we'll gain so much information, as you said, David, on this. So this is exciting.
Yeah, and I think whatever results we get from the clinical trial, I think the analyses of the patient samples will help generate future hypotheses for future clinical trials in the future.
As I understand, this is probably the first radiation oncology study we did with SARC. Is that correct?
That's right.
Part of that is having radiation oncology at the table, understanding the lingo where the radiation oncology field is moving is important. And, part of where you are at the institution you are right now kind of set the standard in North America of the way radiation is done, how we monitor acute and long-term toxicity. But a lot has changed over the years. And I know the fractionation, the way we're planning to have given radiation oncology historically might be evolving. And maybe for our audience, maybe you can describe kind of what are the kind of the lingo words that we should be using when we say external beam radiation. It's not just one type of radiation. And maybe you can walk through a couple of the scenarios so people understand.
Yeah. So radiation therapy can be given in many different forms. There's external beam radiation, where you have a linear accelerator that can deliver high energy X-rays to the tumor. But there are other ways to deliver radiation therapy. There's brachytherapy, where catheters can be placed into a tumor bed, and then a radioactive source can be put into the catheters to deliver the radiation directly into the tumor bed. And then there are other types of radiation besides X-rays. There's electrons or protons that can also be used to treat sarcomas. They can all be very effective, and they each have kind of pluses and minuses in terms of their ability to treat tumors and also to spare normal tissues. Radiation can also be given in different ways. So historically, our standard has been giving standard fractionation, which means generally 2 gray per day for 25 sessions before surgery. But there are a number of phase 2 studies now that have tried a higher dose per day of radiation for 15 treatments instead of 25, or even more recently, 5 treatments instead of 25. And we call this hypofractionation. And there's data that's emerging, and we're excited by these studies, but we certainly need comparative phase 3 clinical trials to compare the standard fractionation with hypofractionation, and those studies are now being planned.
That's the exciting part about radiation. And many of our listeners might have had somebody who went through radiation. Well, that radiation, if it was their mom or dad or grandpa, is totally different than the radiation that is being administered and designed right now. You brought up the word electrons, photons. You didn't say photons, but I say photons, as well as protons, and they sound all similar. Can you just give like a simple elevator speech of why, what are the different properties of these external beam radiation? Because we, as the healthcare providers in oncology, get all the time. Well, is this something I should have protons for versus standard photons?
Standard photons or high energy X-rays are an excellent way to treat a cancer like a sarcoma. Um, the these treatments are just like a regular diagnostic X-ray, except they take longer. So instead of just a few seconds or a few minutes of a CT scan, they can take 10 minutes or more for a treatment. Um, but they're painless. The main difference between X-rays and protons are that X-rays go into a patient and then exit out the other side. And so one can shape the radiation dose distribution by having multiple photon fields coming in from different angles and directions, kind of like a spotlight that all shine on one person that's on a stage. And so the radiation dose is highest at the tumor, but is low in the surrounding normal tissues. Protons, on the other hand, go into the patient and then stop at the target. And so there's less exit radiation kind of in the low dose region away from the tumor. Interestingly, with X-rays, you can actually get a much sharper dose gradient in the high dose region. So sometimes with proton radiation therapy, you end up giving more high dose radiation to the surrounding normal tissues than you do with X-rays. And so there can be situations, clinical situations, where photons are better, and there can be clinical situations where protons are better. And that's why you need a radiation oncologist to evaluate the patient, to look at the different plans and decide what makes the most sense for that patient.
I will reiterate what Dr. Kirsch just said. Rely on your expertise of your radiation oncologist to make the decision what type of radiation. Don't rely on me as a medical oncologist saying this, no. But you're right. And what we're hearing is that as there's more and more experience with protons, the way the fields are designed, it actually might be preferential to do a certain type of um, energy beam compared to the others. So I think this is why you need to go to centers that have a lot of experience of what needs to be treated, and they'll figure out the right method and the right energy to give for that. So I do think that's an important aspect. And I know that, David, you work a lot with other cooperative groups, and now your role at Princess Margaret is to kind of standardize a lot of what's going on in that field. But as we start to see other sarcomas being managed in a lot of different areas, where regions of the world and in the United States and Canada, what do you see are the major questions that are going to be something that's going to be important for sarcoma oncology moving forward?
Well, I think for sarcoma oncologists, I would say, you know, on a first step, what we do here in Canada, and especially in Toronto, is we have centers of excellence. So here at Princess Margaret Cancer Center, we're the sarcoma center for Toronto. So the Greater Toronto area patients all come here for sarcoma care. And I think that's a real advantage, where you have a number of surgeons, medical pediatric oncologists, radiation oncologists with a lot of expertise. And I think that's important that we try to centralize care as best we can for sarcomas, because I think that gives our patients the best outcomes. Areas that I think are really ripe for investigation, as we mentioned with radiation oncology, I think hypofractionation is really critical to understand whether we can safely reduce the number of treatments for patients. I think randomized phase 3 clinical trials are really important to answer that question. And specifically, I think the tumor control is likely to be the same, but the question is, will we have different or more long-term toxicities from hypofractionation? We really need to understand that. And then I think circulating tumor DNA is a very exciting area where we can detect minimal residual disease after surgery and radiation therapy after the local therapy is finished. And I think other disease sites in oncology, like rectal cancer, for example, colorectal cancer, they're kind of ahead of sarcoma with this. And I think there are going to be hopefully trials in the future with adjuvant systemic therapies that can be based on circulating tumor DNA in sarcomas. I also think that there's a lot of potential for targeting the fusion oncoproteins that drive many sarcomas with novel small molecule drugs that specifically block the driver function. And with SARC-32 and other innovative approaches of RNA vaccines and others, I think we can hopefully stimulate the immune system to fight sarcomas in ways that other more common cancers, there's been some success.
Well, that's a research agenda for the rest of my career. So this sounds pretty exciting here. However, you did bring up the point of hypofractionating, having centers of expertise. I do know that there's been some studies that have been done where you tailor a little bit the type of radiation, the schedule of radiation potentially, based on the histology. So knowledge of those histologies is getting more and more important because you just don't treat every single sarcoma the same. And kind of like to hear your thoughts on that.
Yeah. So there are some sarcoma subtypes that are exquisitely sensitive to radiation therapy. So for example, myxoid liposarcoma, these tumors really shrink a lot, usually during preoperative radiation therapy, almost like a lymphoma would. And the really beautiful work from Rick Haas and colleagues at the Netherlands Cancer Institute showed that they could give 36 gray in 18 fractions instead of the standard 50 gray in 25 fractions for myxoid liposarcoma. That data is now maturing. They have excellent local control, almost 100% local control, and the follow-up is maturing quickly. And I think as long as the local control remains high in the years ahead, I think that's likely to become a new standard of care. And so that would change how we treat patients. Instead of giving 25 treatments, we would give only 18. And I think there are other nuances. There are over 100 different types of sarcomas. Myxofibrosarcoma is very, especially the superficial myxofibrosarcomas can be very infiltrating, and we have to be really thoughtful about our radiation field sizes and margins specifically for that subtype because they have much higher rates of local recurrence than other like undifferentiated pleomorphic sarcomas, for example. So I think that's a reason to be seen by a sarcoma center, by radiation oncologists that have a lot of comfort and expertise with sarcoma, so they can understand how to tailor the radiation therapy and the overall treatment for each type of sarcoma.
Yeah, you're right. So it's how much you give, what fractions you give, what the field you start to do is going to be critical as we, continue to build out, expertise within the radiation oncology field in sarcomas. As we think about it, people are always afraid of the acute side effects of radiation, or at least I am, as well as the long-term side effects. And with modern technology, can you give an idea to the group, what are we expecting for just general feelings on the short-term acute side effects and more importantly, the long-term side effects?
It's hard to give a blanket statement. It really depends on the details of the case, how big the tumor is, exactly where it's located. But for extremity sarcomas, in general, preoperative radiation therapy is very well tolerated. With modern techniques, sometimes there can be some skin redness. Very occasionally now we see patients with kind of what looks like a sunburn with a severe radiation dermatitis, but usually that's not the case. Fatigue is very common, so about half of our patients have some fatigue with their radiation therapy. I think the major short-term toxicity really is that we double the risk of a wound complication when we give radiation therapy before surgery. And so if your surgeon says the risk is 1%, we'll make it 2%. That happens in the upper extremity. In the lower extremity, for proximal thigh sarcoma, the risk can be as high as 17% or even 20% with just surgery alone for wound complication where there can be an infection in the wound after surgery. And with preoperative radiation therapy, you can double that to 40%. So I think that's the main risk with preoperative radiation therapy. The long-term risks really depend on the technique that's used, how the radiation covers the normal tissues. And we worry about fracture of a femur, for example. So we're very careful with our radiation dose to try to keep it within safe radiation dose constraints. And then there can be fibrosis or scarring of the tissues. There can also be swelling or edema of the extremity. And there can also be joint stiffness depending on how much of the joint's in the radiation field. And then with some of the more aggressive types of hypofractionation, there was a study from Brazil, for example, that gave 8 gray times 5 fractions, so 40 gray and just 5 fractions. This was clearly too much preoperative radiation therapy. There they saw vascular complications, and some of those patients required amputation. And so that's why we have to be very careful with our clinical trials to really understand the long-term side effects of our radiation therapy. But we know with decades of experience with preoperative radiation therapy of 25 fractions at 2 gray that it's quite safe. But the other long-term complication from radiation therapy can be a new cancer that can happen many years, even decades after the radiation therapy is given, where a new cancer, a different type of cancer, can form. That's rare, but that's another potential long-term side effect of the radiation therapy.
I'm even understanding more and more that when we ask a very simple question and patient says, what are the side effects of chemo? It depends on what drug, multiple things. And when we even talking about what are the side effects of radiation, there's a high level, and it's different if it's upper extremity, lower extremity, location to a joint, what's the fraction that you use, so et cetera. So I do think this is why having an expertise to discuss that with the patient is best seen by a radiation oncologist. I'm not getting paid by the radiation oncologist to say that, but it's truly important because, when you do a lot of different types of radiation, you're going to have different potential short-term or long-term. It's best to visit with somebody who has that expertise. So we're a big proponent of multidisciplinary clinics. So that's why we're saying the same thing.
That's right.
You are at a new institution. And I know you're probably just getting your feet wet. No, you've been there a little bit now. Maybe you can describe kind of what's your vision of what you're going to do there at Princess Margaret, as well as how you see us working at SARC and other cooperative groups and Europe would be for sarcoma.
Yeah, well, it's a real honor for me now to be at Princess Margaret Cancer Center, where I'm leading the radiation medicine program. There's a great history here at Princess Margaret in the field, making contributions that really have global impact. We have 30 fellows in radiation medicine from around the world that come to Toronto to learn about all different types of cancers, including sarcoma, and then they go back to their home country and take what they've learned to elevate the care of cancer patients locally. And then specifically within sarcomas, there's a rich history here of our sarcoma program in Toronto making important contributions. The big randomized study of preoperative versus postoperative radiation therapy for sarcomas was led by Brian O'Sullivan and Charles Catton here in Toronto, and many other important contributions have been made by radiation therapists, radiation oncologists, surgeons, medical oncologists, and others. I think that we are excited to make continued discoveries in radiation oncology here. I think there's new cutting edge technology that we'll be testing in the years ahead in Toronto, new ways of imaging cancer right before we give the radiation so we can adapt the radiation treatment as the tumor is responding to radiation treatments. That's one area that we'll be focusing on. I also think there are opportunities to take advantage of the prior few decades of research understanding how cancers and normal tissues respond to radiation therapy, the DNA damage response pathway and the kinases that are turned on, that we can use drugs now to modify that response, potentially making radiation therapy work better. And then following on the heels of SARC-32, we're hoping to figure out ways to combine radiation therapy with ways to stimulate the immune system to make not just radiation work better, but also to make the immune system fight cancer better throughout the body. Another area that's really exciting is the application of artificial intelligence to radiation therapy with radiation therapy planning, the way we design our treatments. We can really learn from our decades of experience and all the work that we've done in the past and kind of integrate that to help make our treatment plans go more smoothly and more quickly for our patients.
There's a lot that's on your plate to do, so this is exciting for us, and I agree. And I think what you kind of said at the end was all of this is to improve the care of our patients that are going through sarcoma treatment. And And I think the field is exciting in the radiation oncology realm, and having you connected and helping guide, trials that we're going to continue to evolve, not only at SARC and other places, it's going to be exciting. So we look forward to what the future looks forward for us for radiation oncology. Dr. Kirsch, is there any other thoughts or questions that you think our audience would like to know about yourself or radiation oncology and sarcoma?
Well, I think the only thing I'd leave the audience with just is how great it's been for me to get to work with SARC over the past 15 years, that we've, I think, really made advances in a lot of different ways on the basic science front, on the translational science, and now with clinical trials. And I think it was nice for SARC, which kind of started out as a medical oncology, cooperative group, to recognize that radiation oncologists could contribute also. And I was really excited that Denise Renke and the other members of the SARC leadership group kind of could see that this clinical trial concept had potential, and that their support was really critical to getting this study launched. So I've been really fortunate to work with such a great organization to do this important clinical trial.
And it's mutual. It's been a great relationship that we've continued to build out in SARC with your group there. Just to let you know, for those that are listening, we are spawning off what we would call a local therapy group to build on what this is. And it's a group of oncologists, radiation oncologists, imaging people that might be interested in dealing with issues of local therapy. Historically, we've done a lot with systemic therapy with advanced disease, but I think we're right. I think we're poised, given the expertise that we have now of how to do local therapies, to move forward. So this is exciting. So Dr. Kirsch, thank you for your willingness to spend time with us on SARC Talk and to share kind of your thoughts and evolution of radiation oncology, not only within SARC, but in the future plans for radiation oncology and sarcoma. And we hope to learn more about the results of SARC 32. So stay tuned as we do that. So anything else, Dr. Kirsch?
Nope, that's it, Dr. Kuno. Pleasure being with you today.
No, thank you. For those that are listening, we will be posting this, and we look forward to our next talk at SARC Talk, and we're going to have Dr. Damon Reed, who will be speaking to us on this, and it might be out of order as you listen to it, so don't worry about it. It might come before or after this, but you'll have another podcast as well. So you guys enjoy the holidays, and we look forward to another podcast in the future.
Thank you for listening. Be sure to subscribe so you never miss an episode of SARC Talk. To find out more about SARC, please visit our website at sarctrials.org. To suggest a topic or for questions, please email us at sarctalk@sarctrials.org. The SARC Talk series is made possible due to funding by Aadi Biosciences and Boehringer Ingelheim. Together, we can find a cure for all forms of sarcoma.